Well, thanks everyone to our ACME stakeholders meeting. We're really excited to have Stephen Scott and his team of College Medical Center here to present to us. So we'll have Stephen, who is the CEO of College Medical Center in Phoenix and has served in this leadership capacity since 2024. He's been involved in providing related behavioral health care in Arizona since 1988. So this is not his first rodeo. In his current capacity, he has been engaged in efforts to reopen and manage behavioral health operations, the oversight of the HVAC, the chiller repairs at the facility
Yes, please.
Formerly known as St. Luke's Behavioral Health in Phoenix. His background includes extensive experience in healthcare operations in level 1 hospitals in the Reba Magellan and Crisis Centers, UPC, and Phoenix. Along with him, he'll have his Chief Medical Officer, Dr. Nazila Adib, a board-certified adult psychiatrist with two decades of clinical and admin experience in inpatient psychiatric care. She earned her medical degree from U of A in 2001, completed her psychiatry residency at Banner University, and has held several leadership positions, including CMO at Banner Scottsdale and St. Luke's, and currently serves as CMO at College Medical. And the third presenter is Daunifa Britton, who serves both as a Chief Clinical Officer and Chief Nursing Officer at College Medical Center Phoenix, with a decade of executive leadership in hospital operations, nursing quality, nursing education, and she is really dedicated. We met her, rebuilding the hospital's reputation by placing patient care at the center of every decision. And she focuses on strengthening teamwork, accountability, clinical quality to ensure that patients and families feel safe, respected, supported. Her goal is to restore trust in the hospital through compassionate care and strong community programs. So let me get your presentation up and then I'll share. Okay. Here we go. Well, that's not as good as the other way. I'll escape out of it because then it blinks our other screen over here. Okay, tell me when you want to start, Stephen, but it's over to you.
I am ready to start now. I just want to thank everybody for taking the time and inviting us to the ACME stakeholder meeting. Really greatly appreciate that. And I don't yet see my team has joined, so they'll probably be joining later. Dr. Adib, are you there? And Donapa, have you had a chance to sign in? That's okay. They'll jump on and I'll go ahead and start with the presentation. Just a quick introduction. I'm going through the participant list, and I know a fair number of you, and I just want to say thank you again for having us here. Please don't hesitate to raise your hand or indicate if you have any questions as I'm going through the presentation. Just a quick bio about myself. Again, as Lori had mentioned, I have been involved in behavioral health services in Arizona in some sort since 1988, when I relocated here from college very long, many years ago. But my first real job as a behavioral health case manager actually was working for Kodama as a children's case manager when it was still located at 99 East Virginia. So it has been a long time ago that was my very first exposure to behavioral health. I see that Gene Cavallo is on the call. Gene was one of my leaders back then, so I always have to make sure I point that out. So I'm always grateful for that and having those early mentors in my early part of my career. Again, I have been involved in the Arizona Medicaid behavioral health system since that time, and have done a variety of jobs. This is my second CEO position. This is the second hospital that I've had the opportunity to run. So I've really I'm standing on the shoulders of a lot of people throughout the years. One of the reasons the college medical which outreached me from Los Angeles, where they're located, is that they were looking for a local guy who had a book of business in the Valley and understood, the intricacies and the importance of behavioral health in our system, and particularly in our county. So, Lori, the next slide. So again, Dr. Adib, our Chief Medical Officer, who we retained from St. Luke's, she'll be joining the presentation, and she'll be part of this call, as well as Donna Paw Britton. She is from Los Angeles. She's from one of our California hospitals. She'll be joining the call as well. Just a quick timeline. College Health Enterprises, which is out of Southern.
Yeah.
Sorry?
I'm taking.
I muted.
Okay. College Health Enterprises, which is out of Southern California, in January of 2024, they started conversations with Steward Healthcare about the acquisition of the St. Luke's campus. As most of you probably know, St. Luke's has been in business and providing some sort of care on this campus, 16th Street in Van Buren, since 1907. So they have been providing, there's a long history of services being provided out of this location. College Health Enterprises had approached Steward and had expressed interest in purchasing this campus, including the entire medical tower, which was closed in 2019, and then the behavioral health center. There were negotiations. They were in negotiations to purchase the property. Then, without their knowledge, in May of 2024, Steward Healthcare filed Chapter 11 bankruptcy. At that moment, College Health Enterprises, they could have made the decision to not move forward with the purchase. They were, at this point, they had not invested any funds in the purchase. But they made the decision. It was within their mission statement to stay. They saw an opportunity here to provide behavioral health services, and to restore some of the legacy that St. Luke's was previously had participated and previously had provided to the larger behavioral health community. In August of that year, so this was last year, and remember, in August of 2024, I was at a competitor hospital less than a mile away. At that point, the AC system, our chiller system here at St. Luke's, goes out. It took them a week, and really took the system really a week to acknowledge what was going on in the hospital. I had received several phone calls that week, but not a lot of collaboration from Steward Healthcare at the time. I received my first phone call at 9:30 on a Friday night, basically asking if I had any beds to place adult patients in. The patient rooms had gotten between 95 and 100 degrees. It's August. They were desperately looking for beds, and so between 9:30 at night on a Friday until 2:30 a.m., my team and I at my other hospital moved 16 total patients. We accepted 16 patients. The last two patients were here in the hospital. They were both requiring one-to-ones. We knew that, but our concern was just getting them out of the environment. So we accepted both.
CEO of
We accepted both of
healthcare
those.
facility.
At that time, in August of 2024, then the St. Luke's license was put on temporary hold, pending a corrective action plan and completion of the IJ for Medicare and another state and federal survey. And at that time, College Health Enterprises said, "Hey, we can do this. We are willing to take on the IJ. We're willing to take on the corrective action plan, the 2567 from Medicare. We are willing to move forward." They were given a temporary license to operate a single adult unit. And in October, College Health assumed operations of St. Luke's via the temporary license. They were not owners of the actual hospital facility just yet. They just assumed the license so that the issues could be fixed on the campus. I came on board in November of 2024. We, by that time, had already submitted a corrective action plan. We started to do repairs on the hospital and within the hospital grounds itself. We had discovered a lot of deferred maintenance that occurred in the hospital. At last count, we were about 2.7 million into repair cost at this time. That included the chiller system, that included completely renovating and cleaning out the kitchen, which had not been licensed by the Department of Health for over a decade. The kitchen is now online and fully operational. That included ligature remediation throughout the units, a ton of paint. The grounds had not been watered or cleaned. There's a lot of vandalism. I mean, there was just a ton of damage to the hospital grounds and to the tower itself. There was no security, so the building was filled with vandalism, unfortunately. So we had a lot on our plate. So we College Health Enterprises fully invested in this. And then we ended up admitting our first patient again, we only had one unit. It was 22 adult beds. We ended up admitting our first patient on December 4th of 2024. And then by March of this year, 2025, full ownership, change of ownership through the bankruptcy court hearing process as well, changed hands from Steward to College Health Enterprises. And then we now have a full operational license for 127 behavioral health beds. I'm sorry, Lou, you're on mute.
I was just going to say that's amazing how fast you guys were able to turn it around and get it ready for patients.
It was a ton of resources. I will tell you, I have never been this supported by an out-of-state leadership team in my entire career. We have constant folks from California flying out, participating. So a lot of kudos to them as well.
Do you see a big difference between the California leadership than you've seen between Arizona leadership? I mean, and you don't have to answer that. So.
Yeah, rose-colored glasses. This is not my first out-of-state leadership team that I have dealt with in my career, and a lot of out-of-state vendors and providers come in and they think that we're the Wild West and that we're not experienced in running behavioral health services or that we're not experienced in operations. And I'm a little biased because I love this system and I love Arizona, but I actually think we have one of the most progressive behavioral health systems in the nation. And I think we have a long, proud legacy to stand on. And I think it takes out-of-state providers some time to recognize that, if they recognize it at all. I'm really fortunate. The California team have just been eyes wide open. How do you guys run your system? How can we be successful? What works? Tell us about your market. So it's been a breath of fresh air, certainly.
That's great. Next slide.
Just about College Health Enterprises. They were founded. I think that's a typo. They were founded in 1968, actually, in Southern California. They're primarily in the LA, Orange, and Riverside counties. And their mission at that time was to assist healthcare organizations in providing quality and cost-effective care. They are a single privately held healthcare management company owned by the Weiss family. So there is no private equity involved. So we have direct access to funding sources and also a lot of direct responsibility to a single family. So during our monthly operation finance reports, trust me, there's a lot of pointed questions that you have to ask. But they have been nothing but open to the idea of what is it going to take to make sure that all 18 acres, including some of our future growth, is taken care of. Just what do we need? So they're really open to hearing from the local team. Right now they're specializing in the operation and management of med-surg hospitals and as well as partial care hospitals. So they have 4 level 1 hospitals in Southern California. They have 12 outpatient PHP programs, a skilled nursing facility, an assisted living facility, and several rehab centers. And they do med-surg. So they have ECT. They have they do a more integrated care product than we're accustomed to out here in the community, out here in Arizona, in our behavioral health hospitals.
You have a question from Helen? You have to unmute, Helen.
I got it.
Okay.
You made the statement, sir, that you view it as the most progressive behavioral hospital that either you have worked at or that Arizona has to offer. And I'm really interested, I'm hoping that you'll give us some of the measures that gives you the freedom to make that statement. My son just passed away, so I'm really
Oh.
looking for good news.
Oh, I'm so sorry to hear that. Very sorry to hear that. Yeah, I think that Arizona and our community for a long time has a really proud legacy that we can stand on in providing recovery and resiliency behavioral health services for this community. It is not an easy path or career that we've chosen to participate in. And again, Helen, I'm really sorry for your loss. And I think that Arizona, though, as a model, has a lot to offer to the behavioral health system and how it's operated in the US.
Thank you.
You're welcome.
And your Dr. Nazila Adib is on, just so you know.
Hi, Dr. Adib.
Hi there. Hi. Whoops, sorry.
Next slide.
Okay.
My grass is not that green. It's better. You can go to the next slide. So here are just some of the services that we're currently offering. So again, we are licensed for 127 beds. There's not a specific population that we're licensed for. However, currently we have 4 units open. So just this weekend, we actually hit 100 patients. So that was a huge milestone from us, given our first admit last December. We're now at 100 patients. Our average daily census is around 82, 83 patients. So we are definitely busy. Right now, we have enough capacity for 103 open adult beds, and we also have a walk-in lobby. So we have our patients. The lobby is not as active as we would like it to be, but we do have a walk-in lobby where we are taking voluntary walk-ins, and as well as voluntary drop-offs from inpatient or from crisis mobile teams. Again, we're changing some operations here from the previous vendor, from what St. Luke's was doing, and we're super focused on programmatic goals and program services. We are trying to beef up our staffing in terms of ratios as much as possible within this particular market. Sorry. And we also are currently operating a walk-in lobby in 103 beds currently. And we also just recently opened up our PHP outpatient program. So our PHP program, partial care hospitalization program, it's called Desert Bloom. It can now operate. It's fully open. We have 11 patients enrolled. It can go up to 40.
Thank you. Next slide.
Future plans. So my first phone call back in November was from Mercy Care. And they asked me if I would be willing to look at and opening a pediatric unit, a unit for children from the ages of 5 to 12. So we currently have a unit, a former adult unit of 24 beds that we are converting to a children's unit. It is not open, and it's not open intentionally. We are really taking our time on opening up this unit. So we are currently reaching out to a ton of stakeholders at the state level, in the community. We're talking about what it means to open up a pediatric unit for kids age 5 to 12. We have a we have children psychiatrists and providers on board that have been with the organization for a number of years. Dr. Adib will be able to speak to that. And we are very intentional about this particular unit. So we are looking at opening up this unit on November 18th, nearly a year after our first adult admission. This one has me, admittedly so, this one has me a little bit nervous. So we're really walking into this and taking our time with this particular unit. Dr. Adib, can you talk about our children's providers for just a bit?
Yes, I sure can. So we are trying to be diligent in terms of making sure we open up this unit to the best of our ability and make it as good as it can be. Our two providers are Dr. Cohan, Lydia Cohan, who both are board certified child and adolescent providers. She has been here she was with St. Luke's over 20 years. And prior to that, she was at Scottsdale Banner taking care of kids. So she will be staying on. And then Dr. Valbuena, who's also a board certified child and adolescent provider, will be joining her. They will be providing the bulk of the care during the week. And then we have some weekend providers to help with weekend and vacation coverage. But she's, she knows a lot of the staff. She's been here a long time, and she really knows the community and is, well equipped in terms of managing some of the toughest kids.
That's great. One thing, I think this doesn't even the images don't do it justice of how pretty this area is. What you did with those old kind of ugly skylights with screening and made them into these beautiful skylights with imagery all around.
Yeah, the hospital was built in 1968, right? And so short of just tearing the whole thing down and starting from scratch, it's really hard to retrofit an older building and make it presentable, and patients need an environment where they're going to be able to feel relaxed and supported. So that's hard to do and retrofit a building. So actually, Lori in another life, in another career, introduced me to an individual that owns this wrap company, and we were able to lean into that resource. So again, Lori, thank you for that. And we were able to put these wraps up into the skylights on the children's unit. Take away the netting that was covering up the windows and the blinds that were covering up the windows. So it really lets in all of this great light into the rooms or into the main milieu area. We're also using the same company for our PHP outpatient program and have wrapped several of our walls there as well.
I think also you guys have been very thoughtful in the neuroscience behind healing in children and deciding paint colors for the walls and the units and other things, because it all matters, right? So that was nice to see when we toured the facility.
And Dr. Adib, can you speak to that, the room that Donna Pa is putting together?
Yes. So we are going to have a sensory room, and is Donna Pa on? Because I in terms of the latest details about the sensory room, I think she's
not yet, but
okay.
But we actually invited the Access medical director and some other folks from Access to come and tour the units and just to provide some feedback. And that feedback this was about a month ago. You need a sensory room. So that actually delayed our opening because, again, we want to be very thoughtful about this process. And so under the direction of Donna Pa and our leadership, she has then gone out and we've identified an area to create a sensory room. We're reaching out to people for the feedback on what that sensory room would look like and just a space for kids, hopefully to address some of that sensory need that kiddos experience. I'd rather have a kid in a sensory room than a timeout room.
Yeah. And I think just really trying to make sure every space is a therapeutic space for the kids, and that, you know, it really is. I think the unit looks so vastly different than what it was before, and it's inviting, and it, you know, it really, the thoughtfulness that's gone into the colors and the wrapping and the sensory room it's going to make a huge impact. I failed to mention our pediatrician, Dr. Stanley Gehring. He's worked here for 50 years, 50. And he's great. He's great with the kids, and he will be performing our physical exams. So he's going to stay on. So it's nice because it's a team that's worked together for a long time, and they've known each other, and you know, it's good. They've been very consistent, and we're excited to open the unit up and have everybody back.
Have you been given any demographic information, or are the people, the children, the adolescents that Mercy Care has that they want to refer, do we know if they're English speaking, or are you going to need translators? Is it going to be people from all over the state, or do we know?
We actually do know. So unfortunately, there's a great need for behavioral health and patient services for kids ages 5 to 12, not only in Arizona but across the U.S. And we do have a statewide footprint, so we will be accepting kids from across the state. So we've actually already met with the court system. We have started conversations with DCS, and we will be, and Mercy Care is a conduit to DCS. We will be working with DCS as well. And the demographics of these kids that they're going to be sending to us, of course, autism is going to be a big one. A lot of kids that are removed from home and have short-term, have CPS involvement, DCS involvement. So far, not a lot of Spanish-speaking kids or Arabic-speaking kids, which are the two second and third largest languages in the Access Medicaid system. But we have full translator services available to us if we need that. We're more interested in actually bringing on a certified school teacher to provide educational services for kids, even though we don't have to at a level 1. It's just the right thing to do. Right, and it's really going to help us focus about treatment planning for the kid involved. The other thing about it, moving the unit to a 24-bed unit, is that it's split in 12. So there's 2 units, 12 beds apiece. They're joined in the middle, but that allows us some flexibility and agility to speak to what the behavioral health needs are on the unit at that time. So whether it's based on age, whether it's based upon gender, whatever it happens to be, we're really going to be flexible in terms of having almost 2 different units at the same time.
Sounds great. Want me to move on?
Yes, please. So here's our future plans. And so I'm sure most of you do remember that when the 9-story tower, which was part of our campus, was open for business. It was open for a number of years, for a rather long time. It was closed in 2019. So the tower, the medical tower, needs a ton of rehab services. We are currently in the middle of rehabbing the lobby and floors 1 through 5. So there is, and that is just the rooms. I mean, so our goal by 3rd quarter of next year is to open up 60 additional medical behavioral health beds in the tower. Part of that will be opening up a wing and a suite for ECT services. And then we're going to be focused on patients with medical comorbidities. So
Great.
we're trying to shy away from a geriatric unit, a senior horizons unit, anything along those lines. We want to be able to treat patients. Again, it's an integrated healthcare product. So we're going to be opening up an additional 60 more beds in the tower.
Great.
And those are just some quick contacts. I don't really know necessarily for if they apply to this team, but again, if that's our referral, our referral process.
Thank you.
Thank you.
Okay, questions for Steve and his team?
Well, Steve, this is Chuck Goldstein. I was on the tour,
Hi, Chuck.
took home some food. It was quite a spread. At the time, I believe we discussed, as you know, as I'm sure you do know, the Association for Chronically Mentally Ill has had as one of its focuses developing secure facilities for patients that need that kind of behavioral health. Okay, and I believe you mentioned something to the fact that you were opening a secure facility. Could you expound on that?
Yeah, absolutely, I could. So I want to backtrack a little bit. This is, and hopefully this helps answers Helen's question a little bit more thoroughly. My leadership team from California is so invested in providing services, right, that they are really open to any ideas that myself and the rest of the local team just bring to them. And so, for instance, of course, it's healthcare in America, right? So a lot of it is revenue driven. And so here I have a leadership team that said, okay, open up a kids unit, boom, 30 days. They were very, very supportive. And when I said, no, we have to be super thoughtful about this process. This is a really vulnerable population. And so here we are almost a year into my tenure as CEO, and they're very supportive. Great. When you're ready to open up that unit, we're going to open up that unit. So, and they've been very supportive of being very thoughtful and intentional about it. When I had also mentioned to them that there is a possibility and that there is a lot of support of having a locked residential program in Arizona, their first thought, their first suggestion was, great, we have 18 acres, let's just build from the ground up.
Perfect.
Right. And so that was their first response to me when I brought it up to them my first week of employment. So, and as we've developed that conversation with them, we have existing space here on the campus, which it'd be cheaper just to rehab an old physical rehab center. It'd be cheaper just to rehab and build out some of an old hospice facility that's on the campus. So as an organization, I will tell you that if there's energy about having a locked residential, we really have full intention of having that locked residential on this particular campus. The continuum of care options and possibilities are just immense. So not only having a walk-in lobby process, having integrated care process, having PHP and level 1 process. So we're super excited about that. So we are definitely open to having that conversation, Chuck.
Thank you.
You bet.
Okay, Patty, you have your hand up. You're on mute.
Mr. Scott, back to, I think what was Helen's question was really about what's going to be different about the services provided by college medical versus what we have now. Because we're in a system that, as family members of this system, that we see, of course, a lot of flaws. We see people dying, our kids dying, and we're really concerned about that. I think the Weisses have their heart in the right place. Sounds like you're going to have wonderful build outs, but what are you going to do different? And are you going to track outcomes? Because that's really what we're concerned with, is the outcomes, not about the check the boxes and isn't this impressive and that sort of thing. No disrespect, but we don't see anybody tracking their outcomes and publishing them.
Right.
The deaths, as well as the the recovery.
Right. Yeah, some great insight, and those are some really, really tough questions to answer. So I'm going to lean into that, right? One of the things I think that my community reputation, you stick around long enough, right? And you earn a community reputation. And one of the things that I'm really proud of about myself and that I can speak to is that I lean into that, fully transparent about those outcomes. Those outcomes are not always good, right?
Right,
And
right.
family members who struggle every single day with either a family member or their own particular issues, right? They don't want to hear a lot of BS about, well, we tried this, we tried that, and they want to be super transparent about those outcomes.
Right.
I do have a pretty good track record of leaning into that, producing those outcomes, and just saying, look, this is about a recovery and resiliency. And so let's start tracking these outcomes. One of the things that we're doing now is that I'm not getting the data that I think that I deserve as a level 1 healthcare provider. So we're actually reaching out to COPA and their organization that they're involved with. And they've developed an organization. We met with them last week, and I said, that's great. If you're having this data that you can share with me, right? And if we can take a look at all the patients that we're currently serving, track those outcomes based upon a 24-hour readmission or a 3-day readmission, what didn't work? And if we're discharging patients before they're ready, and I think Dr. Adib will agree with me, and they're recidivating back into whether it's jail or another hospital, the organization that discharged that patient really has a lot to answer to. But I don't know who that is or who those patients might be unless the community actually is open to me and open to sharing that data with me. So we're trying to figure out that part now with our SMI Revalve homes.
So Mike
Thank you.
Mike Franczak has his hand up. I think
Yeah,
that's you, Mike.
hi.
Hey, Mike.
everybody. Hi. In my experience, outcomes are in the eye of the beholder. A
Sure.
lot of the outcomes that we're being measured by in our contracts are outcomes that our funding agencies want to see reductions in costs, okay? But the family outcomes, I don't think, are articulated very well. They may not be readmission data, or they may not be some of the factors we're tracked on in our contracts. And I would suggest that the lady who spoke, I think Patricia, and was it Helen? That we get together at Acme and identify parent outcomes, which are not necessarily really the outcomes that agencies are being held accountable for today. And like I said, outcomes are in the eye of the beholder. Like, Patricia, what would be an outcome that you would like to see? Not only that, I'm sorry to hear about the passing of your son, but what give me an outcome you'd like to see the system achieve?
Okay, so that was Helen's son,
Oh, yes, I'm sorry.
but it's like our sons, Helen, you want to speak?
Our son was
Yes.
discharged from a hospital on a Thursday afternoon, and he was found deceased on a Wednesday morning. So 6 days later, he was deceased on a city bus stop. So he wasn't ready to be discharged by any shape and by any measure. And those are the kind of measures that I think Patty may have been referring to, but there are 100 other measures. He was under court-ordered treatment. And that's another measure that we need to address. Thank you.
Well, Helen, in your case, if you really try to find out the root cause of what happened there, it may not have been the hospital. It may have been the community provider did not
Absolutely. He was dead
Yeah.
on the bench outside their office.
outside their office. So
Yes.
I don't know. I think it would be a great idea if we had a group get together and articulate family outcomes, and even with peers, and find out what they felt was a good outcome.
Yeah.
Right.
So anyway,
Mike,
Thank
I
you.
think that's a great idea, and I'm open to that. And I'm sure Helen, who's been advocating for her son for quite a while, when she gets over her brief state, would be also willing to come in and
Yeah.
sit down. And I think having the peers give us their opinion about their outcomes that they live would be very helpful.
I
I
would
think,
recommend Christy Dye, who's on the
Very good.
call, facilitate the meeting. So we could, and she's familiar
Right.
with doing something like that, and have Scott
yeah,
and other people there that would be able to contribute.
you know what? I think, Mike, also, my experience, and it's been a while since my son was unstable, but my experience was whenever he was in that cycle of getting in and being picked up and amended, court-ordered treatment was like water off a duck's back, didn't mean anything. I'll say anything to get out of the hospital and then goodbye, and he'd be gone. But what I've a lot of times found so frustrating when he was clearly psychotic still and the meds had not kicked in, the utilization manager at whatever Reba was in charge was hammering them to discharge. And when I would say, but he's not stable. Well, he's going to stabilize in the community. I'm like, when he has no insight, good luck with that. And it didn't happen. It took a long time in the hospital in Valleywise, thank goodness, and then a brief period at Ash. But I think that it's not always the hospital fault. We have to have a really good decision, and maybe our joint legislative committee that Josh is on, holding our healthcare system accountable for people being made to step down, not only from hospitals, but from births too soon. And they drop off into like you said, Mike, into a canyon and fail. And again, this time Helen's son didn't survive that mishap handoff. And I think there's many reasons why the system fails like that, and it's not continuous. And I think we have to address all of them.
You mentioned a couple words there: discharge, handoff, whatever. Those processes, that places that I've seen that do it well, actually call it transition planning. And they sit down and systematically identify exactly what need has to be met in the community. And the hospitals are involved in saying, here's where they are right now in this controlled setting with these medications. However, they're going to be out in the community. It's going to, you got to adjust for it. So instead of calling something discharge, we need to call it transition.
I agree. Patty?
Yes, I just want to add that, yeah, I believe that medication is one of the very obvious factors of failure. When they are moved from one level of care to a lower level of care, oftentimes they're given full charge of their medication, and most of them have no way possible. They're too disorganized in their thinking to make that work. So they're not. So then pretty soon they're not medicated, and then therein it lies the problem. Then we're back in the hospital. Then we're spending all that money doing that round robin thing. So I really think a medication, some kind of an outcome on that, some kind of a factor on that. How we can make sure that person has that continuity of care, as you talked about, instead of discharged from all the care and then into gee, here we are spinning again.
Exactly.
Yeah.
Mhm.
Thank you.
Helen?
I just wanted to say that I think we're hitting on a lot of really important buttons, and I'm not sure that this is what Dr. Scott wanted us to discuss. So you have more slides, Dr. Scott. We don't mean to sidetrack you.
Oh no, I have
Okay.
been participating in these conversations for 30 years, and I
Okay.
fully
Okay.
support everything that is being said here in
Okay.
terms of those outcomes, except for one thing. I'm not a doctor. So
Oh, sorry. Okay. Our daughter Lori when someone said medications, Larry's biological sister, who we also adopted, was discharged from the hospital, and she picked up her meds at ComCare. So, Mr. Scott, you've been around long enough to know ComCare. And she overdosed on her ComCare schizophrenic medicine. So this is our second child.
Oh, I'm so sorry.
Terrible. Hmm. No words. Terrible. Mike, do you have another question?
I don't, although, everybody's right. As soon as, medications are controlled and handed to people, they show up for medication time in the hospital. And the world's totally different in the community in terms of, medication. And it's very important to know ahead of time how they're going to get receive the medications that seem to be working when they go to another setting. And the staff in the other settings have to be very alert and vigilant about, okay, you're not, it's obvious you're not taking your medications. You're not even picking them up. And there's a lot of medication measured. Not every medication is a silver bullet. It does some things and it improves some things, but recovery is much bigger than just taking the right medication. So it's important that medications are continuity in medication adherence.
Agree. Chuck, you had a question or comment?
Yeah, I just want to give everybody that's talking here a little bit of hope in the form, and by virtue of the fact that we have a very talented member of the Association for the Chronically Mentally Ill, we have a number of proposed legislative bills that in one way or another are going to improve everything that we are talking about here. I'm not going to go into those bills. It would take a separate meeting of hours long to discuss them, but I just wanted to let you know that at the legislative level, a lot of the concerns that are being talked about here are being addressed by proposed legislation to make the whole behavioral health system more responsive.
I had another, Jean has her hand up. You're on mute.
Very
Okay.
sorry. Thank you. I just had a question to just kind of clarify the College Medical Center, because a lot of the concerns, which are all valid, that have been expressed, are more related to aftercare, after they leave the hospital. So does the hospital have a step-down program or an outpatient program, follow-up program, or would these patients be assigned to another facility?
So good question. So about 67% of every patient that we serve as an adult is already assigned to a Reba Health Home, one of the SMI outpatient clinics. And so, of course, discharge, the old phrase, which doesn't apply or work sometimes, discharge planning starts at time of admission. So within 24 hours, every single one of those patients, if they're admitted to our facility, we reach out to the assigned Reba Health Home. And as part of our discharge planning is that if they are then going back to that particular clinic, our expectation is the clinic picks them up and then we hand them off. So not every patient that we currently have in-house, though, qualifies for the PHP program, meaning their insurance does not cover it. So that is our only step-down option at this point. But if there are other step-down options, my length of stay here at this particular hospital is really high because we're actually waiting for the residential programs of the referral process from the for the outpatient teams to make a residential referral program for us. So So they can step down to the teams, they can step down to PHP, they can step down to substance use disorder treatment providers, or they can step out to outpatient treatment providers. So, and I loved what Mike said. It's just medication adherence is just one of multiple factors involved in this.
Yeah. Have
Yeah.
you considered hiring functional behavioral analysts for your youth? Because one, they're amazing when they do their job, and two, if they are on the spectrum, even more so. But behavior modification while they're in there, and then training the people there so they know how to do it, and then also the treatment team, once you know the kid and know what's going to work or not going to work. That was a game changer for our son, and it was someone that Mike recommended, worked with our son, and that was a real game changer.
Yeah, we actually have had that discussion, Lori, and so we're hoping that the larger, and we've not been successful in finding an ABA therapist to bring on board, unfortunately, but we have had that discussion with DCS and Mercy Care about making sure that we lean into that specialty because they are game changers.
Mike?
Yeah, one thing, Steve, that I think you were alluding to is billing. It's a billing issue.
Sure it is.
The hospital and the community provider cannot bill at the same time. And that's part of the dilemma, because the hospital can't continue to follow somebody and not get paid. And the provider cannot do things while the person is in the hospital and get paid. So this goes back to Chuck about it's an issue, and I'm not sure you're going to be able to solve it because it's probably a Medicaid rule or something in Washington. But Steve, isn't that true?
That is a billing issue, of course, right? And so that does prevent some of that more comprehensive care being provided to the patient when they're discharged from a level 1. But there's nothing that precludes us from bringing that team in-house and me providing them space and food and internet access. And so that's what I tell when I meet with the Reba Health Homes. Look, nothing stops you from actually coming in every single day, seeing your patient, your assigned individual while they're inpatient. I can give you a space to work. I can give you office space to work. I have 2 psychiatrists currently in the community that they do come in on a regular basis. I think that's something that Kodama and ComCare had in terms of a relationship issue with the outpatient providers. There was more integrated there were more integrated systems of care in the community back in the 90s and the early 2000s. And I think that I'm trying to get back to some of that. I do want these case managers who have a really, really difficult job to come into the hospital, have a place. I'm not going to charge them anything. I just need them to come and see their patient while they're here. That's going to be the best discharge plan I have.
But to Michael's point, when they come in and avail themselves of your hospitality, they're not going to get paid for that.
Well, they can. What if there was another charge?
I won't. They can do case management billing for that, but I just want to see their smiling faces in my hospital.
What if there was another code that didn't double bill, but say when they are within X amount of time of discharge, transitional planning, which is not either or, it's both of you. So couldn't there be a code developed that both of you can work on and still bill?
Right. You're talking about what's going on in the criminal justice system where they're allowing that to happen, but it doesn't translate into the inpatient. It doesn't exist yet, but it's worth a try.
Okay, Crystal, you've been patient.
Thank you. I'm having issues with my mom's dog anyway. So a couple things is one, I think it's great that you're opening up a kids unit, and I'm glad you're putting in a sensory room. You're gonna get a lot of use out of that. You probably would benefit from 2. And I just wanted to give you a name. I was just talking about this. I've been talking about it quite often. So Dr. Partington, and he's out of San Francisco. He runs what's called a STARS program. My daughter was as severe as they get. They wanted her in Phoenix Children's Hospital every year. She was aggressive. She was like a feral animal. She bit, she attacked, she pinched, she pulled hair. The only program that worked to educate her, and she's got, her cognitive abilities are about 40. So I review behavior plans all day long for DDD, for these kids that don't get a program that helps them. So I would suggest looking into something like that, because anybody can run the program. It's actually super easy, and it comes with video instructions, and it comes with a grid model. So I'm going to try to get your email, and I'll try to send you the information. Not that you need my suggestions, but I feel like I feel like it might help to kind of guide and help to be able to help those kids with autism anyway. And then the second part is what I think what us moms are trying to say, and it doesn't matter if they're coming out of Valleywise or Phoenix Med or any of these hospitals, there's no transitional care. So even the births most of the time are a high enough level of care, but we used to have units at the state hospital that were called transitional living units. And especially for the first time that they're being diagnosed or they're being amended because they're just that sick or they're come through the criminal justice system, there needs to, I feel like there really needs to be a unit where there's like a 5-to-1 ratio with the individuals that prepares them for the community, that actually takes them out to the community. And it used to be case managers and stuff. And I know, again, it's back to that funding issue. But if we really, I mean, we're kind of saving pennies, but but then in the long run, we're breaking the bank because they're just going back into the hospital. And not only that, the parents are struggling. The parents are terrified that their kid's gonna hurt themselves or hurt the parent, or that they're just not gonna make it. So um, the secure birth could be like kind of a good step down for a lot of people that just have that dangerousness with them. I don't know. I've spent 2 years now trying to figure this out. And there's a big jump from a hospital to mom. And I know the clinics want to be helpful, but the clinic is not a hospital, and they don't act at all like a hospital. They don't have a social worker. They don't have a counselor. I mean, they do have those things, but the person has to go to them. And it's just a big gap in our system. And the other thing is, even 3 weeks that Valleywise is doing now just is not long enough for people to be stable and to come home to mom. So I had this conversation with Dr. Olson today that and I can't remember who else, another mom, her son got out of the hospital yesterday, and immediately today put grease on her brakes on her car. So, I mean, we just like moms, in a single mom who has to go work. I mean, you're going from, and the first appointment, of course, is tomorrow, so you're going from this to mom. It's just not, it is just not working well. Anyway, that's my spiel.
Yeah.
And
But they shouldn't be stepping down if they're that ill to mom. They should be going to a birth and staying in a birth and do a slow step down. And a lot of these people are old enough, or their parents are, they shouldn't be going back to mom. There should be other systems that help take care of these folks. One question, Crystal, what's the name of that program? The Dr. Paddington in San Francisco?
Dr. Partington, it's Web Ables. It's Ables, ABLLS, I believe. And it's a STARS program. So for kids like my daughter, this was the most interesting thing that I learned. She didn't have mirroring neurons, so she couldn't imitate. So many kids with autism cannot imitate. They can't, if you say do this, they're just clueless. They have no idea. So the first part of the program teaches imitation, which you have to have in order to educate her, or in order to educate a lot of these kids with autism, because they just don't copy. And so it was instrumental. We went out for a couple of his classes. I was crying when he came and talked about all the work he was doing. And I said, it's never going to work for Tia because she can't imitate anything. And we took Tia to San Francisco and learned from him. And I mean, my daughter now, you see her running around and behind me and everything. I mean, she doesn't attack. She doesn't do any of that stuff anymore. We were actually, I mean, she's no rocket scientist, but she's can live with me and she's safe. So, which I think a lot of us, that's what we want with our kids, right? I mean, we want them to be able to live in the community and be safe and just be alive and be able to, you know, be whoever they can be. We don't need them to be rocket scientists or, you know, engineers. And by the way, this Dr. Churn, this individual that I'm talking about is coming to COPA. That just got out of Valleywise. So the mom needs some help. It's his first time diagnosed. It hit her like a brick, and he has some dangerous things that he had tried to do. So
Maybe he's a candidate for first episode center if it's a first episode, if he's young enough.
He's not. He's older. And
Darn.
I think he's going to respond. I just think the mom's afraid. You know, again, like she didn't get a good discharge education and stuff like that. And so she was just terrified. Of course, the first thing he does is put grease on her brakes. So that would make anybody, I think, a little terrified. But
that's danger to others. He should be amended and put right back in. I mean, really, if you think about it.
I talked to Dr. Olson. Dr. Olson's going to call mom, and she's going to fill out a paper to give to the clinic. I don't know how to get a hold of Dr. Churn. If he wants me to, I can. I don't know if I would be violating HIPAA or anything if I give you his name. So.
You're not his doctor. You won't be violating.
Okay. Well, his name is Joseph Rogers, and he's going to your 51st and Bell Clinic. So, and mom thinks he might have had a breakthrough, that he's actually was tearful and doing, she thought that she saw a spark of her old son again, later today. But I'm still concerned. So.
Yeah. So I think Mike has his hand up and Jean has her hand up. Mike has his hand down. Jean?
Hi, Lori. I was wondering if you could comment more or get your thoughts on, were you talking about once they leave the hospital, having better for them to go into a residential behavioral health setting. But that's totally voluntary, even if you're on court-ordered treatment.
It's not. It's up to, if you're a guardian, I think Access made a big mistake when, I think it was Dr. Megan. Anyway, when they changed the protocols and the guidelines and said that you have to get the patient's acceptance, that's wrong. And Josh is on, but we went back and said, you go to court and they don't take away your rights lightly. But when you go to court, and I had this discussion today with another organization, a lot of times they don't understand the fact that the court now said that the ward or your son or daughter, or whoever you're in charge of, cannot make decisions. Now, you always want to get buy-in when you can, of course. You want that, but that's not necessary. And a lot of the health homes were really failing miserably by not understanding guardianship. I think Josh is going around giving guardianship training to organizations because of that.
And and if your child is not, if you're not a guardian of your child, it's voluntary whether they go into a facility. So, and I don't know what the percentage is of, who's, you're on your first court order treatment, they're in the hospital for 3 or 4 weeks. How many actually have a guardianship at that point? I don't know.
I'm not.
That is the issue with this particular gentleman is.
There is. I'm just a little hazy here, so those of you who know better on this call could, like my wife, for example. Once you get court ordered into treatment, and the part of the court order is that you live in a specific place.
They don't do that.
No.
No.
They say your court order is to adhere to treatment in your treatment plan, and you can be in the hospital up to 180 days, 85 days with renewal, but it's up to the clinical team how they interpret if you're violating your treatment plan. The good teams, I can say, won't blow you off when you say, but they haven't taken any of their oral meds in the last 3 months. Some worse teams will say, oh, we don't amend until they miss their long-acting injectable. The better teams will say, okay, if they're taking that for a bipolar aspect of a schizoaffective, they're not going to get better without that mood stabilizer. So it depends on the team, but right now they do not order you into a behavioral health home. They leave it up to your clinical team, and Dr. Churn or others can talk about that.
Well,
I can't hear you.
According to the statute does not allow the court to order them into a residential behavioral health home, so it's voluntary.
And at this point, it's really hard to enforce any order for someone to stay in a specific place because they walk out as soon as they want to so but that's true, like the team should consider that as part of the treatment, the placement of the patient, and should try very hard to make sure that the patient is in a location that's conducive for improvement or recovery. Yeah. By the way, just that when I found out that Steve is going to be CEO of our new facility here in Arizona, I was optimistic, when I heard about that, because from the time that I started working here in Arizona as a direct provider and later on as CMO, he has always been helpful in pushing for good patient care. When every time I reach out to him and ask for his help, he has always he has been generous in making sure that he hears our side of the story, the outpatient side of the story, and that he always advocates for good patient care. So I'm very optimistic that him being at the helm of this inpatient service, that we'll have some improvement in our service. Yeah.
Can I just say
Thank
one
you,
more
Dr.
thing to
Churn.
Scott? I think this is a great opportunity when you're talking about adding the secure residential behavioral health facilities, that you also add non-secure and offer your patients a place to go from the hospital.
So my California team, my corporate California team, they've already asked me that question. Trust me. So they really want me to be open to the community needs, and I have 18 acres I can play with. So
That's great.
yeah.
So Helen, you had a comment or question?
Yes, I just wanted to comment on one of my things I've been hammering on for this last year is that in our state, court and our county, for sure, court-ordered treatment is meaningless. One of you made the comment that It has a few teeth. If our son got his injection once a month, that was all he had to do. And that did not meet the expectation, I'm sure, that the judge had in mind when Larry was, he's been court ordered for 10 or 15 years, but it seems to be getting less and less meaningful as we move forward throughout Larry's life. We saw less and less teeth in it till finally, I think the last 2 years, it was, does he get his injection? So every Friday, I wrote his Taros team and said, do you have an update on Larry? And the first reply was, he is compliant with his court-ordered treatment. We saw him, da, 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 da. And that was it. That is what court-ordered treatment means. So this past year, there was a really positive initiative, and I don't remember the number of the bill, but it's written down somewhere. The people who wrote it know. And that bill was to add some teeth to court-ordered treatment. And it passed the House and the Senate, which was very encouraging. But then for political reasons, it never got the final approval, blessing before it would go to our governor. So to me, that's a really important issue that we need to resolve.
It's a money bill. I mean, if they're going to say they must provide, they shall provide, that's a money bill. So I think that's why it died.
Actually, I believe there was substantial evidence that it costs more to have Larry in the hospital for months in intensive care and for months with a terrible catheter infection than if they had given him the appropriate care at the right time.
Yeah.
Thank you.
Patty?
The other issue with court order treatment is the renewal or when that court order is expiring. What we're hearing a lot from families is that the clinics didn't let anybody know. They didn't let the family know, and the clinics just let it expire. So I don't know if that's another bill that we need to have, but that's really important because we need to know if that's going to expire. And we need to advocate if we believe that that should continue or be renewed or whatever the right terminology is. So, important one.
I will just say that, referring back to what I said before, that concern is being addressed in the proposed legislation.
We'll see if we have someone that picks up and runs with it. Yeah. Okay. I don't, again, I don't want to dominate your time. So it's been an hour and a half. So if you